surgeon from the Houston Methodist Hospital and the surgical principal investigator on the Evolute low-risk trial. And it's a pleasure this morning to talk to you a little bit about the results of that trial. With Jeff Popma, our cardiology principal investigator, we've run a series of trials across the spectrum of surgical risk. Our first trial was the high-risk trial, where we had a primary endpoint of all-cause mortality at 1 year. We found that TAVR was superior to surgery. That superiority was maintained at 2 years, and at 5 years we had similar survival. We ran the intermediate risk trial, SURTAVI, where we used a Bayesian analysis to get an interim early look and showed for a primary endpoint of all-cause mortality, disabling stroke, TAVR was non-inferior to surgery. We've also looked at the full 2-year data set that Dr. Popma presented at TCT 2018, and with the full 2-year data set with standard Kaplan-Meier statistics, we showed there were no changes in outcome and no changes in conclusions, validating our Bayesian approach. So this trial was to look at TAVR with the Evolute supraannular self-expanding valve compared to surgical aortic valve replacement in patients that have a low predicted 30-day surgical mortality. Now this trial is a multinational randomized prospective trial. We're going to use a Bayesian analysis that allows us an early interim look when 850 patients have hit 1 year. That would require us to recruit 1,200 patients using an absolute non-inferiority margin of 6%. And we'll use our as-treated group as our analysis group. And using a Bayesian analysis, we have to have a posterior probability curve of greater than 0.972 to have a win, because that'll give us an alpha error of less than 0.05. So we actually recruited 1,468 patients, and the reason we did that is the FDA required a leaflet thickening immobility CT sub-study, and to complete that sub-study we had to keep enrolling patients, which gave us over 700 patients in each intent to treat arm. There were some dropouts, and we still had a high number, over 700 TAVRs and almost 700 surgeries in our as-treated RNA analysis group. So what we do is when 850 patients have reached 1 year, we have 3 groups of patients we can look at. Group A have already made 2 years, we know their endpoint. Group B have had an event, but they have not reached 2 years, but we know their endpoint also. Their endpoint is imputed as having an event. Then we have Group C, they have not made 2 years, they have not had an endpoint. But by knowing where they are in the trial and knowing how others in their arm of the trial have gone in reaching an endpoint, we can then create a risk model that allows us to predict or impute the probability of them having an event at 2 years. And so we then use this risk model to move them forward to 2 years. We do this for each and every individual patient and then calculate a posterior probability curve. We repeat this 100,000 times and integrate all 100,000 curves to smooth out any invariability to get the final posterior probability curve. And if it's greater than 0.972, we have an early win and we're allowed to look at our data, and that's exactly what happened. So if we look at the Bayesian predicted endpoint for 2-year all-cause mortality or disabling stroke, for surgery, it was 6.7%. For TAVR, it was 5.3%. That gives an absolute difference in favor of TAVR of 1.4%. And using the absolute non-inferior margin of 6%, it gives us a posterior probability curve of greater than 0.999. This is highly non-inferior to surgery. In fact, we do a worst-case sensitivity analysis where every surgical case that dropped out that doesn't have data is imputed as having no event. Every TAVR case that drops out and has no data is imputing as having an event, making it as bad as we can for TAVR. We rerun the analysis, and TAVR still maintained non-inferiority, which is a very strong finding. Now, we had 7 hierarchical powered secondary endpoints. There were 4 for non-inferiority, mean gradient, EOA, change in NYHA at 1 year, and change at KCCQ at 1 year. And then there were 3 that if we passed non-inferiority we could move to, and that was mean gradient and EOA at 1 year and change at KCCQ at 12 months. All these passed. So for superiority, mean gradient, EOA at 1 year, and KCCQ at 30 days was superior for TAVR. Now we had a variety of other secondary endpoints that we looked at. We have a composite safety endpoint, which is all-cause mortality, disabling stroke, life-threatening bleeding, atrial fibrillation. There's one more, I'm sorry, I'm kind of forgetting it, but it's a composite endpoint. And then we looked at pacemakers at 30 days, and we looked at aortic valve reintervention. We looked at hospitalization for heart failure, and a couple others at the end of this. But these are non-powered secondary endpoints. So if we move on to what we saw at 30 days, our composite safety endpoint was significant in favor of TAVR, as were the subcomponents of bleeding, stroke, and atrial fibrillation. And all-cause mortality or disabling stroke was also significantly in favor of TAVR. Surgery, however, had less pacemakers. We moved on to a year, what we saw was disabling stroke and rehospitalization were significantly in favor of TAVR. So what does that really tell us as we move forward? Well, we can look at some Kaplan-Meier. So it's at 1 year we actually have enough to a good Kaplan-Meier, and the mortality for TAVR was 2.3%, and surgery was 3%. That had a log rank of about 0.416, didn't reach statistical significance. If we look at disabling stroke, it's 0.6 for TAVR, 2.7 for surgery. That was significant for TAVR, and hospitalizations 3.2 for TAVR, 6.3 for surgery. That was significant for TAVR. So if we look at the combined endpoints, the kind of final thing, we met our primary endpoint of all-cause mortality or disabling stroke as strongly non-inferior at 2 years. At 30 days, TAVR had a better safety profile with less disabling stroke or mortality, less stroke, less atrial fibrillation, less kidney injury. And by the way, you got out of the hospital in half the time of surgery, and your KCCQ went up faster, where surgery had less pacemakers and less residual aortic regurgitation. So the safety profile for TAVR looks really good. And at 1 year, if you were a patient in this trial, I would tell you that if you were assigned to the TAVR arm, you were more likely to be alive without a disabling stroke and without heart failure hospitalization, and that was significant for TAVR to the 0.004 level. So that looks pretty good for TAVR too. So in conclusion, I think we've shown we made our primary endpoint, 30 days looked good, 1 year looks good. The findings from this would suggest that in the patient group we treated, TAVR is not just an alternative to surgery, but TAVR is actually the preferred therapy for surgery, should have a class 1 indication. And maybe we should start looking at TAVR valves like any new surgical bioprosthesis.